Bismillahirrahmanirrahim. Assalamu alaikum. I welcome all my students to today's lecture regarding how the food that is taken inside the body and how that is made possible to pass throughout the body, and how the absorption takes place, how the churning, how the cutting, and each and every process in detail one by one. So today we are going to learn about the ingestion of food, the process of chewing the food, that is mastication, the process of taking the food inside from mouth to the esophagus, and that is the swallowing mechanism. Now what is it? We are going to learn it today, one after the other. Now, what is hunger? The amount of food that a person ingests is determined principally or particularly by the intrinsic desire for food, and that is known as hunger. Now, the more the hunger is, the more the person is determined to take food in the body. Now, the type of food that the person preferentially seeks is determined by the appetite. So you can say that the appetite depends upon the person's liking, preferences as well. Now, mastication. The teeth, they are admirably designed for the process of chewing. The interior teeth, incisors, they provide a strong cutting action, and the posterior teeth, the molars, they are having the grinding action. All the jaw muscles, they are working together so that they can close the teeth with a force as great as 55 pounds on the incisors and 200 pounds on the molars. Look at the power with which they are having the ability to grind the food, to cut the food. See the muscles. Now, the nerve supply or the innervation of the muscles of chewing or the muscles of mastication. Now, most of the muscles of chewing, they are being innervated by the motor branch of the fifth cranial nerve, and the chewing process is controlled by the nuclei in the brain stem. The stimulation of specific reticular areas in the brainstem's taste centers will cause rhythmical chewing movements. Also, the stimulation of areas in the hypothalamus, amygdala, and even the cerebral cortex near the sensory areas for taste and smell can often cause chewing. So, whenever you are being asked about the muscles of mastication, the fifth nerve should be there in your mind. Now, one of the things which is very important is the chewing reflex. Much of the process of chewing is caused by a chewing reflex. The presence of a bolus of food in the mouth at first initiates a reflex inhibition of muscles of mastication, which allows the lower jaw to drop. The drop in turn initiates a stretch reflex of jaw muscles, which leads to rebound contraction. And this automatically raises the jaw to cause the closure of the teeth, but it also compresses the bolus again against the linings of the mouth, which inhibits the jaw muscles once again, allowing the jaw to drop and rebound another time, and this is repeated again and again. Now, what is the importance of chewing reflex? We should be knowing about it. The importance. Chewing is important for digestion of all foods, but especially it is important for most fruits, raw vegetables, because these have indigestible cellulose membranes around their nutrient portions, which must be broken down so that the food can be digested. Chewing aids the digestion of food for still another simple reason. Why? That is, because the digestive enzymes they act only on the surfaces of food particles. Therefore, the rate of digestion is absolutely dependent on the total surface area exposed to the digestive secretions. In addition, grinding the food to a very fine particulate consistency prevents excoriation of the gastrointestinal tract and increases the ease with which food is emptied from the stomach into the small intestine and then into all succeeding segments of the gut. Now, what is this deglutition or swallowing? Deglutition is the act of swallowing through which food or liquid bolus is transported from the mouth through the pharynx and esophagus into the stomach. And it has three distinct phases. Now, it is actually, you should be knowing about it, that it is a smooth, coordinated process which involves a complex series of voluntary and involuntary neuromuscular contractions and typically is divided into three distinct phases. And what are they? They are oral, pharyngeal, esophageal. In general, we have the following phases. The first one, that is the voluntary stage, which initiates the chewing process, the swallowing process, that is the oral phase. Number two, that is pharyngeal stage. It is involuntary and it constitutes passage of food through the pharynx into the esophagus. Then we have an esophageal stage, another involuntary phase which transports food from the pharynx to the stomach. See, this diagram is very important, which is showing the swallowing center and nerve supply, swallowing center, and peristalsis. And it should be from GIT. See how the bolus of food enters, how the nerve supply that is there, how the first stage, then second stage, and third stage that is functioning. See, we have the oral phase or the buccal phase, pharyngeal phase, and then we have the esophageal phase. Now, swallowing is a complicated mechanism, principally because the pharynx serves the respiration and swallowing. It has two functions at the same time. The pharynx is converted for only a few seconds at a time into a tract for propulsion of food. Voluntary stage of swallowing. Now, when the food is ready for swallowing, it is voluntarily squeezed or rolled posteriorly into the pharynx by the pressure of the tongue upward and backward against the palate. From here on, swallowing becomes entirely or almost entirely automatic and ordinarily cannot be stopped. Then comes the second phase, and that is involuntary again. That is the pharyngeal stage of swallowing. Now, as the bolus of food enters the posterior mouth and pharynx, it stimulates epithelial swallowing receptor areas all around the opening of the pharynx, especially on the tonsillar pillars, and impulses from these pass to the brain stem to initiate a series of automatic pharyngeal muscle contractions as follows. The soft palate is pulled upward to close the posterior nares to prevent the reflux of food into the nasal cavities. The palatopharyngeal folds on each side of the pharynx, they are pulled medially to approximate one another. And in this stage, there is a formation of a sagittal slit through which the food must pass into the posterior pharynx. This slit performs a selective action. It allows food that has been masticated, that has been chewed sufficiently to pass with ease. Because this stage of swallowing is going to last less than 1 second, any large object is usually impeded too much to pass into the esophagus. The vocal cords of the larynx, they are strongly approximated, and the larynx is pulled upward and anteriorly by the neck muscles. These actions, combined with the presence of ligaments that prevent upward movement of the epiglottis, cause the epiglottis to swing backward over the opening of the larynx. All these effects acting together, they're going to prevent the backward passage of food into the nose and trachea. Most essential is the tight approximation of the vocal cords, but epiglottis helps to prevent food from ever getting as far as the vocal cords. Now, if there is destruction of vocal cords or of the muscles which approximate them, it can cause strangulation. See? The upward movement of the larynx also pulls up and enlarges the opening to the esophagus. At the same time, the upper 3 to 4 centimeters of the esophageal muscular wall, called the upper esophageal sphincter, also called the pharyngeo-esophageal sphincter, relaxes. Thus, the food moves easily and freely from the posterior pharynx into the upper esophagus. Between swallows, this sphincter remains strongly contracted, thereby preventing the air from going into the esophagus during respiration. See? The upward movement of the larynx also lifts the glottis out of the mainstream of blood flow, of food flow, so the food mainly passes on each side of epiglottis rather than over its surface. And this adds still another protection against entry of the food into the trachea. Now let's talk about the nervous initiation of pharyngeal stage of swallowing. The tactile stimulation of posterior mouth and pharynx for initiating the pharyngeal stage of swallowing lie in a ring around the pharyngeal opening with greatest sensitivity on the tonsillar pillars. Impulses are transmitted from these areas through the sensory portions of the trigeminal glossopharyngeal nerves into the medulla oblongata, either into or closely associated with the tractus solitarius, which receives essentially all sensory impulses from the mouth. The successive stages of the swallowing process are then automatically initiated in orderly sequence by neuronal areas of the reticular substance of the medulla and lower portion of the pons. The sequence of the swallowing reflex is the same from one swallow to the next, and the timing of the entire cycle also remains constant from one swallow to the next. The areas in the medulla and lower pons that control swallowing are collectively called the deglutition or swallowing center. Now we should be knowing about the nervous control of swallowing center to the pharynx and upper esophagus that cause swallowing are transmitted successively by the following nerves. And what are they? They are the 5th cranial nerve, the 9th cranial nerve, the 12th cranial nerve, the few of the superior cervical nerves. So we can say in some, if we want to summarize, is this. The pharyngeal stage of swallowing is principally a reflex act. So we should be knowing about the nerve supply of swallowing. Now, effect of pharyngeal stage of swallowing on respiration. What is it? The entire pharyngeal stage of swallowing usually occurs in less than 6 seconds, thereby interrupting the respiration for only a fraction of a usual respiratory cycle. Swallowing center specifically inhibits the respiratory center of the medulla during this time, halting respiration at any point in its cycle to allow swallowing to proceed. Even while a person is talking, swallowing interrupts respiration for such a short time that it is hardly noticeable. Now, the esophageal stage of swallowing. The esophagus normally exhibits the 2 different types of peristaltic movements. And what are they? They are the primary peristalsis and the secondary peristalsis. The primary peristalsis is simply continuation of the peristaltic wave beginning in the pharynx and then spreading into the esophagus during the pharyngeal stage of swallowing. And this wave passes all the way from pharynx down to stomach in about 8 to 10 seconds. Now, the food which is swallowed by a person who is in the upright position is usually transmitted to the lower end of esophagus even more rapidly than the peristaltic wave itself, in about 5 to 8 seconds. because of the additional effect of gravity pulling the food downward. Then comes the secondary peristaltic wave. Now, if the primary peristaltic wave fails to move into the stomach, all the food that has entered the esophagus, the secondary peristaltic waves result from distension of esophagus itself by the retained food. Now, these waves, they continue until all the food has been emptied into the stomach. The secondary peristaltic waves, they are initiated partly by the intrinsic neural circuits in the myenteric nervous system and partly by reflexes which begin in the pharynx and are then transmitted upward through the vagal efferent fibers to medulla and back again to esophagus through the glossopharyngeal and vagal efferent nerve fibers. Musculature of pharyngeal wall. The musculature of pharyngeal wall and upper third of esophagus is striated muscles. Therefore, the peristaltic waves in these regions are controlled by skeletal nerve impulses from the glossopharyngeal and vagus nerves. In the lower two-thirds of the esophagus, the musculature is smooth muscle. This portion of the esophagus is also strongly controlled by the vagus nerves acting through connections with the esophageal myenteric nervous system. When the vagus nerves to the esophagus are cut, the myenteric nerve plexus of the esophagus becomes excitable enough after several days to cause strong secondary peristaltic waves, even without support from the vagal reflexes. Therefore, even after paralysis of the brainstem, swallowing reflex, food fed by tube or in some other way into the esophagus still passes readily into the stomach. See, the bolus of food is swept along esophagus by peristaltic contractions, and the lower esophageal sphincter is closed. As the peristaltic wave reaches the end of esophagus, the lower esophageal sphincter opens and it allows the ball of food, that is the bolus, to move into the stomach. Then we have the receptive relaxation of stomach. What is it? Now, when the esophageal peristaltic wave approaches towards the stomach, a wave of relaxation is transmitted through the myenteric inhibitory neurons and it precedes the peristalsis. Furthermore, the entire stomach and to a lesser extent even the duodenum becomes relaxed as this wave reaches the lower end of esophagus and thus are prepared ahead of time to receive the food propelled into the esophagus during the swallowing act. At the lower end of esophagus, extending upward about 3 centimeters above its juncture with the stomach, the esophageal circular muscle functions as a broad lower esophageal sphincter, also called the gastroesophageal sphincter. Now, when we are doing these ingestion type of things, we should be knowing the pathophysiology is related to it. We should be knowing about what is achalasia. Achalasia. The gastroesophageal sphincter normally remains tonically constricted with an intraluminal pressure at this point in the esophagus of about 30 millimeters of mercury, in contrast to the mid portion of the esophagus which normally remains relaxed. Now, when a peristaltic swallowing wave passes down the esophagus, there is a receptive relaxation of the lower esophageal sphincter ahead of peristaltic wave, which allows the ease of movement of the swallowed food into the stomach. So really what happens is that this sphincter is not going to relax satisfactorily, and it is going to result in a condition known as the achalasia. The stomach secretions, they are highly acidic and they contain many proteolytic enzymes, whereas the esophageal mucosa, except in the lower 1/8 of the esophagus, is not capable of resisting for long digestive actions of the gastric secretions. Fortunately, the tonic constriction of the lower esophageal sphincter helps to prevent significant reflux of stomach contents into the esophagus, except under abnormal conditions. Additional prevention of esophageal reflux by a valve-like closure of the distal end of esophagus. Another factor that helps to prevent reflux is a valve-like mechanism of a short portion of the esophagus that extends slightly into the stomach. Increased intra-abdominal pressure caves the esophagus inward at this point. This valve-like closure of lower esophagus helps to prevent high intra-abdominal pressure from forcing stomach contents backward into the esophagus. Otherwise, every time we walked, coughed, or breathed hard, we might expel stomach acid into the esophagus. So, let's see question related to this lecture. Can be like, a 40-year-old man presents with the symptoms of upper gastrointestinal discomfort, dysphagia, and a non-specific feeling of pressure or aching in the chest. The radiographic findings indicate distension of the lower esophagus. What is the most likely diagnosis? What is the cause of this condition? So I hope all of you must have a good reading of the topics we have covered today, so that a sort of foundation regarding the GIT physiology should be there with you when we'll discuss this topic further. So stay blessed and Allah Hafiz.